Moving on, the next presentation is in charge of Dr. Ninava from Rostock and is titled Management of Chronic Type B Dissection, the Role of TEVAR. Dr. Ninava.
Dr. Mascaro, Dr. Young, ladies and gentlemen, it's a privilege for me to be invited here and talk to you surgeons here as a cardiologist. But I'm trying to get into this topic and into this matter very quickly. But before we actually embark on a little journey of 20 minutes, the term chronic and the role of TEVAR need to be addressed, I think. We are changing now. Chronic is not the chronic that we dealt with a couple of years ago, and TEVAR is an emerging concept that hadn't been mentioned actually in the treatment paradigm published a couple of years ago in 2008 here in the Lancet. The endovascular approach, or TEVAR, wasn't even part of the armamentarium of treating acute or chronic aortic dissection. Now, however, we have access to it, and it's part of the armamentarium, particularly in type B or in distal aortic dissection. Now, a little bit on the chronic nature of a dissection. We're talking type B, of course, and this is a segmentation that had been basically distilled from IRAD, from the International Registry, that probably was a blueprint as well for your ARCH registry again. Congratulations. This will be an IRAD reloaded, or better IRAD. Again, from this international registry, we collected data that kind of allowed us to segment the dissection on a timely domain into hyperacute dissection, obviously in the first 24 hours, followed by 7 days of acute dissection, and then subacute up to 30 days. And beyond 30 days, everything is considered to be chronic. That has some implications. If you, for instance, look at the survival curves of patients subjected to endovascular TEVAR as compared to medical management, in that particular frame, beyond 1 month, there seems to be a difference, or could be a difference, in favor of endovascular management. And of course, that took off already. You know that in the recent years, TEVAR has taken part of the treatment algorithm in dissection. We now know from a retrospective analysis of IRAD again that we are dealing with different types of type B dissection, a so-called high-risk group, the classical hypotension, malperfusion, rupture group, and on the other end of the line is the lower risk group. I wouldn't say uncomplicated, I don't like that term, but the lower risk group that has a lower attrition and ends up with a 42% mortality after 4 years. But of course, this is higher than any person who doesn't have any kind of dissection. Here's just to lead into the subject, a case of complicated type B dissection, no perfusion to the lower part of the body, increasing lactate, of course, placement of a stent graft and a stent into the true lumen, and of course, reperfusion of the lower part of the body, sudden decrease in lactate, and resolution of the problem. That can be easy, like shown in that very case, or can be more complex with a petticoat, a distal extension with bare metal components, or even more complex using staged procedures to address re-entry sites in various locations. If you successfully do that exercise, you can put the patient on a stable course over time, and this is data from Long Beach. They had taken care of acute complicated cases, and basically after an early hazard, they can, with successful treatment, put the patient on a long-term survival with no further attrition within 5 to 6 years. That basically made TEVAR the best choice in complicated dissection, which has been summarized in this little review here. But let's talk about the patient that embark into the chronic group of dissection, those that sustain more than 30 days, the so-called low-risk group. Do they actually benefit from TEVAR? Or is TEVAR a choice, a treatment choice in these particular patients? Some of our colleagues like to call these patients non-complicated or uncomplicated, eventually reaching the chronic phase of dissection. There's some evidence from the surgical world that shows the survival pattern of these patients that survive into this phase of chronic dissection. And as you can see here, this is patients just on drugs, blood pressure control, usually beta blockers or combination therapy. Again, within 5 years, there is an attrition up to 42%, similar to the observational data in the IRAD registry, if you just leave the patient on medication. with a considerable control of blood pressure, as you can see here, you still have to face a 42% mortality over 5 years. What happens in time is the patient has no symptoms. They usually are well controlled if they are followed, but they expand their false lumen. This is observational evidence from a patient that came over the years and ended up with rupture, contained rupture, after his false lumen expanded, as you can see here nicely. Patient on blood pressure medication, on surveillance. That was basically the background for looking into this problem of chronic uncomplicated type B dissection. Patients with that characteristics of being chronic beyond 1 month, uncomplicated in classical terms, were subject to a randomized trial, the so-called INSTEAD trial, looking at patients that underwent stenting versus those that were just controlled under medication. Of course, the stented patients also underwent medication and blood pressure control. It was set up to look at mortality after 2 years and various secondary endpoints such as remodeling, degree of expansion, quality of life, etc. Here's a case, one of the early cases in that study, that showed what we're kind of trying to achieve. A remodeling signal is placing a stent graft over the entry side, which you can see here. The false lumen thrombosis, the true lumen slowly opens up with time, and the entire aorta shrinks a little bit. That's the signal of remodeling that we want to achieve. The patients were included in the chronic phase, but most of them in both groups within the first month and the third month, within 90 days. So 85% of patients were clustered in that first chronic phase between 1 and 3 months, or 90 days. This is what happened. The two groups didn't separate in terms of statistical difference with the endpoint cumulative survival within 2 years. There was no evidence to show that the stenting was protective within 24 months. But both groups actually did better than expected. We should have expected a mortality up to 15% or 12 to 15% by the time. That was obviously due to the fact that we randomized the patient was seen, his blood pressure was controlled, they were followed. However, they showed within 1 and within 2 years a crossover rate from conservative management to elective stenting or even open surgery because of expansion, because of some late signal of risk, which became significant at 14% after 1 year and 20% after 2 years. If you looked at aorta-related mortality or sudden rupture, essentially, again, no difference between the two groups. So there was no early benefit of this so-called preemptive intervention in chronic type B dissection. And even if you looked at freedom from progression, meaning a cluster endpoint of conversion, secondary interventions, or death, then there was, again, no difference between the two groups, highlighting the need for follow-up of these patients, no matter how you treat them. What was interesting to observe in the treated group, in the interventionally treated group, was the signal of remodeling, what I showed you in that one example, the thrombosis of the false lumen, the complete reopening of the true lumen, although the stent was only placed here in the upper part of the thoracic descending aorta. That obviously is important. Independent data from a Japanese study recently published, I think in 2014, showed exactly a similar observational evidence that remodeling, as we described it, is a key to success. Patients that do not show remodeling have an ongoing attrition of mortality or events affecting their survival. Patients, however, that show evidence of remodeling, again enjoy this plateau and a better long-term outcome. We looked at our own data and found that the time of intervention within the initial 90 days obviously led to better results in terms of remodeling, whereas patients that underwent stenting in the late phase, beyond 90 days of impact, got less remodeling, here in red as compared to blue. In other words, the window of plasticity and the window of opportunity is obviously closing by 90 days in the chronic phase. Here's another example that shows you what happens over time. Again, a case with an early intervention in the chronic phase after 4 weeks, closure of the proximal entry side. Acutely after the intervention, you see the true lumen the true lumen opened, no more perfusion in the false lumen, even down at the level of the abdominal aorta. And then with time, after 1 year, you saw almost no residual false lumen thrombosis anymore because it's completely shrunken around the true lumen. Perfusion, of course, to all side branches. So the sealing of the entry tears obviously causes this healing or remodeling over time. Again, this could be supported by distal expansion or distal extension with open configuration stents that allow to be stented across side branches and do not compromise them. As another example is shown here, complete false lumen thrombosis induced by proximal stenting and distal extension. This, of course, was a patient who didn't expand. He was intervened pretty early in the chronic phase after 4 weeks and showed nice long-term outcome. Again, if you address the distal re-entry sites, like in this particular case, and this is a patient in that so-called stable trial, you can ensure the patient, or you can put the patient on a stable long-term follow-up line in order to and avoid any kind of late complication within that observation period of 5 years, again in that trial. If the patient is left alone, it's stable patient with type B dissection and just followed over time, irrespective of excellent or less excellent blood pressure control, you usually observe this. This is after 3 years of a patient who was randomized to medical management alone. You see the constant or ongoing expansion of the false lumen, a chronically compressed true lumen, although there may not be any kind of clinical signs of malperfusion yet, but this is all going to be evolving into a stable, very chronic and harsh tissue that is difficult to treat long eventually after that time, probably best by open surgery and replacement of that segment. But with TEVAR technology, to treat such a chronic, almost stiffened lamella is very difficult to achieve. And there's no data except some very small series and observational evidence that this should be done in that late period. Again, what can happen as well is sudden rupture because of the wall tension onto the false lumen with time or progression to the ascending aorta, like in this example. Unpredictable, obviously somehow related to the duration of the false lumen expansion and of course to the diameter to a certain degree. With this in mind, the before mentioned INSTEAD trial, this randomized trial, was now decided to be, by an amendment, to be prolonged with another 3 years of follow-up. And what you can see here, with mortality as a first endpoint, is the additional 3-4 years of follow-up of these randomized patients into medical management with the option of crossing over or primary stented or preventive stenting if you want, in red. And as you can see here, the same kind of plateauing effect kicked in these early chronic cases, similar to those complicated cases. And if you slice that by landmark analysis into separate curves after 2 years, after 1 year, and even after 1 month, you can appreciate that it's always the late phase that basically gets the benefit from this early intervention, which of course was associated with some hazard. So the intervention early on is an investment into a stable long-term follow-up. And the same is true for cardiovascular death as a secondary endpoint, and similar for the cluster endpoint of progression that I just explained to you. Less progression in the initially scaffolded or stented group, ongoing progression in the initially medically treated group. And the same kind of landmark analysis shows the same signal again. Similar to this, or in parallel to this, randomized study, the IRAD registries collected data, again, over 5-year follow-up, comparing patients with endovascular treatment in a similar fashion like the randomized trial, comparing them to medical management. This is about 250 cases, it's close to 700 cases. It's not a randomized trial, it's not level 1 evidence, but shows exactly the same signal that the two curves, survival curves, kind of diverge after close to 2 years. And the reason why more patients ruptured in this group is obviously explained by the increasing diameter after 5 years of the entire aorta. It's a significant difference between the total aortic diameter in that group as compared to the scaffolded group. Probably one of the reasons why there is a difference. Remember this graph, the classic attrition rate of patients on medication. If you project the IRAD, the INSTAT data onto them, you see that the parallel shift is due to better medication and better follow-up of these patients, but the horizontal line can only, or this plateauing effect can only be achieved by scaffolds. We looked in the meantime onto some risk factors that are not obvious. I mean, we're talking uncomplicated, complicated patients in our interaction, but there may be silent risk factors that we can identify already today and identify patients that are clinically silent with no obvious complications, but already with signs that we should pick up and use for our selection for treatment. One of them is a classic sign published a couple of years ago by our Korean colleagues, which is the early expansion beyond the critical diameter of the false lumen. They said it was 22 millimeters in the Korean population. So if you find on your diagnostic CT a stable patient with a large with a large false lumen diameter beyond 22, you are dealing with a patient at risk for further expansion and eventual rupture. The two Kaplan-Meier curves are dramatically different. If you identify a patient with a large entry tear, on echo, for instance, very simply done, you can estimate that this patient will end up on this Kaplan-Meier curve if he's not undergoing repair, usually with open surgery in the ascending or with stenting in the descending aorta. So this is after repair, this is without repair, if the diameter of the entry tear is more than 12 millimeters. Another interesting sign in a clinically silent patient could be partial false lumen thrombosis. Obviously, some correlate of an ongoing inflammation. These patients with that signal do worse with a higher mortality than patients with complete thrombosis or no thrombosis. Here's a case, one of our patients who refused treatment, large entry tear, partial false lumen thrombosis. At the same location, he had an inflammation sign by PET FDG imaging and eventually rupture in that location. This slide has been shown before this afternoon. It is actually an example of an interesting observation that our colleagues in Liège, some colleagues of ours that we collaborate with, made and published earlier this year, which is again a sign of local inflammatory reaction in the wall of the descending dissected aorta. This is the CT image, and this is the PET images that shows you ongoing inflammation locally somewhere here in that part of the aorta. That was the signal that tempted the colleagues in Liège to stent this aorta and eventually observe not only a nice reconstruction of the true lumen, but also kind of a silencing of this signal of inflammation. So the inflammation faded away, the biological markers such as platelets and D-dimers normalized after this step has been enacted, and obviously the inflammation was put to rest. Another interesting observation evidence comes from IRAD again. Patients with elevated blood pressure or difficult to treat blood pressure, although they may be clinically silent, or patients with recurrent bouts of pain are candidates for later complications. And probably some functional imaging, and this is work in progress, some functional imaging may also help to identify sweet spots on the false lumen outer wall or weak spots that may be prone to rupture in a given patient, although he may be clinically completely silent. It would be called an uncomplicated chronic type B dissection. So remember this case. I showed you initially 10 years ago, one of the early INSTAT patients. By the newer criteria that we just went through, for instance, the size of the entry tear and the rapid expansion early on, he would not qualify as a chronic uncomplicated type B dissection today. With the insight that we have, he has already two signs of lurking complication. One is the large entry tear, the other is the early expansion. And he would not be a candidate, by the knowledge of today, to be just followed on beta blockers. So taking the classic criteria that I just mentioned and that you're all aware of, together with the recent criteria, the so-called clinical risk markers, I think there's not many patients left that you can really consider chronic and uncomplicated. In other words, I think the paradigm has shifted. We have to prove that a patient is really stable long-term and has no risk involved. The European Guideline Committee, European Society of Cardiology Guideline Committee, basically recognized that and granted a 2A class recommendation, level B, to treat uncomplicated type B dissection using TEVAR. That means it should seriously be considered whether the patient at risk or the patient considered to be on clinical grounds uncomplicated be a candidate for elective TEVAR. Here's the paradigm that we probably should use today. Stanford type B dissection, we have to check the entire list of potential complications and check whether the patient doesn't have one of them. If we can really identify a patient with no lurking complication, I think, then it's okay to just leave him on drugs. So my final slide is here. It summarizes my thoughts. Dissected aortas on drugs don't remodel and don't heal. Long-term and late complications, as I showed you one or two examples, are very difficult to treat, and the rupture date is difficult to project and to predict. Preemptive TEVAR ensures long-term stability. Various sets of data have shown that and proven that. And I think it is on us to, rather than justifying TEVAR today, I think we have to justify not to offer endovascular scaffolding to a patient considered to be clinically stable in a chronic phase. Thank you very much.
Thank you very much for that presentation. Any questions?
It is like a selling pension policy to a young individual with a 0-hour contract employment. I know that long-term from a prospect is good by having pension, but I don't know how many hours I'm going to get the pay by this on this job. While you're going to kind of contribute the money towards pension scheme. This is like doing TEVAR for acute or subacute type B dissection, I think, but gradually getting more and more convinced that if we can avoid the long-term complication from chronic type B by intervening early, I think probably we'll have a better quality of life for aortic surgeons. But when do you think the right timing to stent these? Because you see that kind of from your evidence as well, many other papers, early phase TEVAR cause a high risk of mortality and morbidity with the retrograde type A's and so many other problems.
Excellent question, very important for our clinical handling and algorithm. I think as long as a patient doesn't show any imminent problems, such as malperfusion or extra-aortic leakage of blood and all that, we have time. We don't have to rush. We don't have to treat the patient within 7 days. We have time. We can use that obvious window of opportunity up to 90 days efficiently. And for instance, what we do in our setting, we call the patient back if he's completely stable and is not really intrigued to get treatment invasively or surgically. We call him back for a PET scan within 3 months. If the PET scan is positive, as this example showed, then we kind of convince him to get treatment. There is already, I think, enough evidence for that, although he may be clinically completely silent. If the patient agrees to be treated with this preemptive concept, we use these 90 days after impact to treat him in an elective fashion. There's some more data. I didn't show that for some other reasons. There's data that has been published looking at uncomplicated type B dissection in the first 10 days or 7 days. And there is no additional benefit if you treat the patient that early. You don't need to do that. You don't lose a patient within 7 days if he doesn't have really other imminent problems. So I think it's wise and smart to not rush too quickly, keep the patient in the hospital for 7 to 10 days, adjust his blood pressure properly, explain the problem, and then call him back in an elective way within 90 days. And if you don't have any data to convince, or if the patient doesn't really understand that or doesn't want to understand that, I think the PET after 3 months can help to generate more evidence, supportive evidence.
Thanks. We have time for just one more question.
Just very quickly, is there a contraindication to stenting at, say, 30 days if you've got organ perfusion from false lumen? We often see this, don't we, that perhaps stenting in that situation, you could end up losing that organ.
Yeah, this is always a concern. But again, this thought had been brought up earlier this afternoon. If you realign the lamella properly, and then you can do that probably best in that early phase up to 30 days, then you just can expect that the lamella and the natural fenestration fall into place onto the orifice of the side branch. For instance, the left renal artery is always an issue to discuss. It happens this way that I never really lost an organ due to that intervention. And if I wasn't happy with perfusion due to some misrealignment or so, there's always an option to put a little orifice stent there and take care of that problem. But even with the petticoat concept, you can still do that and go through the meshes into the orifices and clarify the issue. So the answer is no, there's no risk to create an organ malperfusion by that intervention.
Thank you very much.